Hello everyone and welcome. Thank you for joining me today. I'm Dr. Asim Hussein, and I will be guiding you through this presentation on toxicology emergencies. Specifically, we'll be focusing on paracetamol, also known as acetaminophen, and its toxicity. Over the next few minutes, we'll explore the key aspects of paracetamol poisoning, how to recognize it, and what steps to take in emergencies. Let's get started and delve into this important topic. Let's look at this case. A 34-year-old woman who took some unknown amount of paracetamol 6 hours ago. She's currently asymptomatic, and her blood tests are still pending. The key question here is, what's the most appropriate next step? Now, considering her current status, she's asymptomatic, but we know that paracetamol toxicity can sometimes be silent initially. What we really need to do is decide how to manage her safely while waiting for lab results. The options include discharging her if she remains asymptomatic, measuring her paracetamol level immediately, and plotting it on a nomogram, starting NAC right away without blood tests, waiting 24 hours for liver function tests, or giving activated charcoal only. It's important to remember that in cases like this, early intervention, particularly with NAC, is crucial if we're concerned about toxicity, even before lab results come back. But in this scenario, because she's asymptomatic and blood tests are pending, the best course is to measure her paracetamol level immediately and plot it on the nomogram. This approach allows us to assess her risk accurately and decide whether to initiate NAC treatment promptly or continue observation. It emphasizes the importance of targeted, evidence-based decision-making in managing poisoning cases. So, the key takeaway here is that prompt measurement and plotting of the paracetamol level help guide us to the most appropriate and timely intervention, ensuring patient safety while avoiding unnecessary treatment. Let's take a closer look at the correct answer, which is B now. The key point here is that when you're measuring paracetamol levels, if the sample is taken 4 hours or more after ingestion, you need to plot that level on the RUMEC, Matthew nomogram. This nomogram is a critical tool for guiding treatment decisions. It helps us determine whether an overdose is likely to cause toxicity and if we should proceed with antidotal therapy, such as acetylcysteine. So, in summary, timing matters. After 4 hours, use the nomogram to interpret the level appropriately. This step is essential for ensuring we provide the correct and timely intervention. All right, let's look at this scenario. We have a 70 kg man who came in about 10 hours after ingesting 18 grams of paracetamol. His level on the nomogram is above the treatment line, which indicates a significant risk of hepatotoxicity. The key here is understanding the timing and the level of poisoning. Since the level is above the treatment line and it's been over 8 hours, the best course of action is to administer intravenous N-acetylcysteine, or NAC. This antidote works by replenishing glutathione stores in the liver, helping to detoxify the harmful metabolites of paracetamol. Other options like oral methionine or activated charcoal alone aren't sufficient in this context, especially given the high level and the delayed presentation. Supportive care alone might be necessary, but isn't enough as a primary intervention when the level is above the treatment line. Observing and repeating levels in 24 hours is also important, but immediate NAC administration is crucial here. So, the correct management in this case is IV N-acetylcysteine, which is represented here as option B. It's the standard, evidence-based approach for cases like this, where the risk of liver damage is high. Let's take a look at the correct answer, which is B now. The key point here is that any level above the nomogram treatment line indicates the need for IV NAC or intravenous N-acetylcysteine. This is true even if the patient isn't showing symptoms. So, even if the patient appears asymptomatic, if their position on the nomogram crosses that treatment threshold, IV NAC is indicated. This underscores the importance of accurately interpreting the nomogram and understanding that the treatment line is a critical cutoff point. It ensures we're providing the necessary intervention early enough to prevent further complications. Remember, the goal is to identify those at risk and treat proactively, regardless of symptom presentation. This slide reinforces that concept within our overall theme of timely and appropriate management. Let's look at this case. A patient comes in 36 hours after an overdose, experiencing nausea, right upper quadrant pain, and significantly elevated liver enzymes with ALT at 4200 IUL and an INR of 3. Interestingly, their paracetamol level is undetectable. Now, what does this tell us? Well, first, it highlights that even if the paracetamol level drops to undetectable, the liver damage can still be severe and ongoing. This underscores the importance of clinical judgment and lab findings over just the level. Given the timing, more than 24 hours after ingestion, and the elevated INR, which indicates impaired liver function, the mainstay of treatment is to support the liver and prevent further injury. In this scenario, administering IV N-acetylcysteine remains crucial because it can still provide benefits even beyond the initial 8 to 10 hours. So the best answer here is C, IV N-acetylcysteine. It's essential for managing such liver toxicity, especially when the patient presents late, with evidence of hepatic injury, despite the paracetamol level being undetectable. This case really emphasizes the importance of recognizing and treating acetaminophen overdose early, but also knowing that treatment can still be beneficial even later on. All right, let's look at this important point. The correct answer here is C, which is highlighted with a check mark. Now, the key takeaway is that late presenters, even if they show signs of hepatotoxicity, can still benefit from N-acetylcysteine or NAC. This is crucial because it emphasizes that treatment shouldn't be stopped just because the paracetamol level has dropped to 0. Often, we think that once the toxic drug level is gone, the damage is done, but that's not the case with NAC. It continues to provide protective effects and supports liver recovery even in later stages. So always remember, if a patient presents late with liver damage, don't withhold NAC. It can still make a significant difference in their recovery. This ties into our overall theme of early and continued intervention being vital in managing paracetamol poisoning effectively. Let's take a look at this question about the mechanism behind liver injury in paracetamol overdose. The options are quite specific, so it's important to understand the underlying process. Now first, we know that paracetamol, or acetaminophen, is generally safe at therapeutic doses, but when taken in excess, it can cause severe liver damage. The key here is to identify which mechanism best explains this injury. So let's go through the options. Option A suggests direct hepatocyte necrosis by paracetamol itself. While paracetamol does cause cell death, this is not the primary mechanism. Rather, it's a consequence of a specific metabolic process. Option B points to immune-mediated hepatitis. This is more characteristic of drug hypersensitivity reactions, not typical of paracetamol overdose. Option C refers to depletion of glutathione allowing NAPQI accumulation. Now, this is central to our understanding. When paracetamol is metabolized in the liver, a small fraction converts to NAPQI, a toxic metabolite. Under normal circumstances, glutathione neutralizes NAPQI, but in overdose situations, glutathione stores are depleted, leading to NAPQI accumulation and subsequent liver cell injury. Option D mentions mitochondrial uncoupling, which is more relevant in other toxicities, but not the primary mechanism here. Option E talks about bile duct obstruction, which is characteristic of cholestatic injury, not typical of paracetamol toxicity. So the most accurate answer is C, depletion of glutathione allowing NAPQI accumulation. This highlights the critical role of glutathione in detoxifying reactive metabolites and explains how overdose leads to hepatocellular injury. Connecting this to our overall theme, understanding this mechanism is essential for effective management, including the use of antidotes like N-acetylcysteine to replenish glutathione levels and prevent further damage. The correct answer here is C, and let me explain why. When there's an overdose of paracetamol, our body metabolizes it into a compound called NAPQI. Now, NAPQI is actually quite toxic to our liver cells, or hepatocytes. Normally, glutathione helps detoxify NAPQI, neutralizing its harmful effects. but in cases of overdose, glutathione stores get depleted. Once that happens, NAPQI can't be detoxified and starts causing significant damage, leading to the death of liver cells. So, understanding this process is crucial because it highlights how an overdose can quickly lead to liver injury if not managed promptly. This connects to the overall theme of how important it is to recognize and treat paracetamol poisoning early to prevent serious liver damage. All right, let's take a look at this question. We're asked to identify which finding best predicts a poor prognosis and the need for urgent transplant assessment. The options are quite specific, so it's important to understand what each one indicates. First, an ALT level of 1500 IUL. That's a significant liver enzyme elevation, suggesting liver injury, but on its own, it doesn't necessarily mean immediate transplant is needed. Next, an INR of 1.8 indicates impaired blood clotting, which points to liver dysfunction. An INR over 1.5 is often used as a threshold when considering transplant because it reflects the liver's ability to produce clotting factors. Then, a pH less than 7.3 after resuscitation signals metabolic acidosis, which is a marker of severe systemic deterioration and poor perfusion. This is a critical sign that the patient's condition is worsening and may require urgent intervention. Detectable paracetamol levels, especially if within the therapeutic range, may not be as alarming unless there's evidence of overdose. And vomiting at presentation, while concerning, is quite common in many cases and doesn't directly predict prognosis severity. So, connecting all these points, the most concerning indicators for a poor prognosis and the need for urgent transplant assessment are those that reflect the severity of liver failure and systemic impact. In this context, a pH less than 7.3 after resuscitation is especially significant because it shows ongoing metabolic derangement despite initial treatment. Therefore, out of all the options, the most reliable predictor here is a pH less than 7.3 after resuscitation. The correct answer here is C, and I want to walk you through why. The King's College criteria are a key tool we use to assess whether a patient with acute liver failure might need a transplant. Essentially, if the arterial pH drops below 7.3, that's a serious sign of metabolic decompensation. Alternatively, if the INR exceeds 6.5, or if the serum creatinine is over 300, or if the patient shows signs of encephalopathy, these are all indications that the liver failure is severe enough to warrant a transplant referral. These criteria help us make timely decisions, which can be life-saving. Remember, recognizing these threshold values is crucial because they guide us in identifying patients who are unlikely to recover without transplantation, and prompt referral can significantly improve outcomes. So, this slide emphasizes the importance of specific lab and clinical parameters in the decision-making process. Let's walk through the typical timeline of paracetamol toxicity. In the first 0 to 24 hours, patients often experience mild nausea and vomiting, which can sometimes be overlooked or mistaken for other less serious issues. Then, between 24 and 72 hours, we see the onset of hepatic injury starting to develop. This is when liver cells begin to be damaged, signaling the beginning of more serious problems. From 72 to 96 hours, the situation can escalate to peak liver failure, which is a critical period where liver function is severely compromised. At this stage, the patient may show signs of jaundice, coagulopathy, or even encephalopathy. Following this peak phase, patients may either recover if they receive prompt and appropriate treatment, or the condition can worsen, progressing to acute liver failure, which is life-threatening. Understanding this timeline is crucial because it helps us recognize the progression of paracetamol toxicity early on, so we can intervene before irreversible damage occurs. It ties into the overall goal of our presentation, highlighting the importance of early detection and management in poisoning cases. Let's talk about diagnosis in paracetamol toxicity. One key aspect is measuring the paracetamol level, but importantly, This should be done at least 4 hours after ingestion. Measuring too early can give misleading results, so timing is crucial. The most commonly used tool to interpret these levels is the RUMAC, Matthew nomogram. This graph helps us determine the risk of toxicity based on the serum paracetamol concentration and the time since ingestion. If the level crosses the treatment line on this nomogram, it indicates a need for intervention. In addition to the paracetamol level, we need to look at other markers to assess the extent of liver injury and systemic effects. These include liver function tests, or LFTs, which tell us about liver health, as well as INR, which indicates blood clotting ability, lactate levels, and arterial blood gases, or ABG, to evaluate acid-base status and metabolic disturbances. All these tests together give us a comprehensive picture of the patient's condition and help guide our management in paracetamol toxicity. Remember, early diagnosis and appropriate assessment are key to preventing severe outcomes. Let's talk about treatment, specifically IV N-acetylcysteine, or NAC. This should be started immediately if the patient's level is above the nomogram line, which indicates a high risk of toxicity. It's also crucial to begin treatment if the time of ingestion is unknown, since delays can make management more difficult. Additionally, even if the presentation is late, but there's evidence of liver injury, NAC can still be beneficial. The key point here is that prompt administration of NAC can significantly improve outcomes in paracetamol toxicity cases. So, always remember, early intervention is essential to prevent severe liver damage. Let's talk about pearls for managing this condition. First, it's crucial to treat patients based on their risk level, not just their symptoms. This means that even if someone isn't showing obvious signs if their risk is high, they still need prompt intervention. Second, late presenters, those who come in after the symptoms have appeared, still benefit from NAC or N-acetylcysteine, which can be life-saving even when started later. This highlights the importance of not dismissing late presentations. There's still a chance to make a difference. Third, early transplant referral can be critical and can significantly improve survival rates. Recognizing when a transplant might be needed and referring promptly can be the key to saving lives. Now, moving on to the topic of paracetamol toxicity, it's essential to understand that it can be severe, but is also highly treatable if caught early. The main message here is that prompt recognition and treatment based on risk assessment are the cornerstones of effective management. Thank you so much for being with me throughout this presentation. I really appreciate your time and attention. I hope the insights shared today have been helpful and have given you a clearer understanding of the key concepts we've discussed. Remember, the ideas we've explored are all about driving progress and making a positive impact. So, thank you again for your engagement and interest. I look forward to any future discussions or collaborations. Have a great day.